has responded to my question on Instagram sticker, so thank you for that. So I'm going to kick off with that before I forget. And that question says, what about loose skin after liposuction, how to treat it and how to prevent it? So this is a big question, to be honest with you. It's a very good question, and it's a problem, and it's a problem that people have tried to solve, because liposuction will only remove fat. So liposuction doesn't remove skin. I think sometimes when people are kind of big, they think, oh, liposuction will be good, and it is good to remove fat, but it doesn't remove skin. So in the same way that when you lose weight, I mean, it's basically like losing weight essentially. In the same way that when you lose weight, you often have loose skin, and therefore need a tummy tuck or a mastopexy or a breast lift or mastopexy or an arm lift or a thigh lift or whatever it is. Those operations are really skin tightening operations. They're not fat removing operations. So a lot of cosmetic surgery is kind of skin tightening operations rather than fat removing. The best way to remove fat is to lose weight. And if in my hands and in my experience, and at the end of the day, this is probably one of those areas where people have different views. So my view is that liposuction is good at doing the same as what weight loss does. And so the situations where it's really useful is in situations where you've lost weight, but there are some stubborn areas which haven't, which are still full. Outer hips, so-called saddlebags, outer thighs, male chest. There's certain areas which respond well to liposuction, and certain areas which don't respond so well to liposuction, because the skin doesn't recoil. So this is the question: how do you address loose skin? And that is classically the central abdomen, inner thighs, arms. Those are areas where, in my experience, the skin doesn't recoil so well. So what do you do about that? Well, it's a really tough area, because the kind of most predictable way to tighten that skin would be to cut that skin out and do an arm lift or a thigh lift or a tummy tuck, which is basically what those operations are. They're cutting out that skin to tighten the skin, but they're big operations. And so the problem comes in patients who aren't sort of candidates for those big operations, but want the skin to be tightened. And that is an age-old problem. And there are lots of different modalities out there that people report to treat it. And anytime there's lots of modalities means there's no one good one, but it's difficult. And we've looked at it in our clinic, getting in some of these sort of technologies, but haven't really embraced any, I'll be honest with you, personally. So I personally haven't embraced any of the technologies. The technologies, by technologies, I mean things that, if you like, maybe damage is just the wrong word, but kind of like heat up or deliver energy to the skin to cause it to kind of tighten, to cause it to retract, because that's what you're after. Liposuction is great at removing the fat, but you want that skin to tighten up. And it's very hard to give back the skin its elasticity. If you have loose skin, it is loose for a reason. Usually it's kind of damaged skin, if you like. The skin has been stretched, whether that be through weight gain or whether that be through pregnancy. The skin has been stretched, the skin has been damaged, the skin has lost its elasticity. Also aging, sun exposure, smoking, all these things will contribute to the loss of elasticity of the skin, and we can't really give it back its elasticity. I wish there was something we could do to give it back its elasticity, so you go back to a teenage sort of physique in terms of the sort of the consistency, if you like, of the skin. But unfortunately, as old Father Time ravages us all, the skin just doesn't recoil as much as we like. So if you put on weight or if you have children, the skin maybe doesn't recoil as much as you like. And as I say, liposuction can get rid of the fat, but it doesn't tighten the skin. And so in answer to the question, the things to do are, well, I don't do liposuction to the central abdomen or the inner thighs and areas where I'm worried that the skin won't retract, because I feel, and I feel that you could potentially make it worse by doing liposuction to those areas. If you're not removing skin, if you're just removing fat and no skin, you can make the skin hang more. So I don't do it because it has been average at best in my hands. So how do you avoid that problem? As I say, I don't do it. Some people, there are technologies out there. So some people talk about vaser liposuction, which is an assisted form of liposuction, which delivers energy to the skin before you do the liposuction, energy to the fat, not the skin. And so they report that will cause some degree of skin retraction. So that's a type of liposuction which delivers energy to the fat before you remove it. There's also things that you can do to the skin, so you can deliver the energy to the skin with radio frequency and external devices which will deliver energy to the skin, which will cause, they say, a degree of skin retraction. There's these non-surgical methods of fat removal, which remove the fat by either giving heat or cold or radio frequency or whatever it is, some kind of energy to the fat, which will kind of kill the fat, but it won't kill the skin, but it does have an effect on the skin. And they say these things can cause some skin retraction. So that would be the way to go if you are kind of not a candidate for a full skin excisional procedure like a tummy tuck or an arm lift or a thigh lift. But the problem I found when we've looked at them is their subtle results have to be done in combination with weight loss regimes and exercise regimes and keeping healthy, keeping well hydrated, keeping good skin quality, and they're expensive. That's the problem. The machines cost a fortune. They've often got a lot of consumables, so they're really expensive. So I worry about charging people a lot of money for an average result. I think that's a recipe for a rocky road, which I don't really want to go down. So I haven't embraced any of them, but they're certainly worldwide. They're very popular. These sort of radio frequency or whatever cooling, heating sort of technologies, which say they cause skin retraction. So the answer is talk to someone who does it, I guess. Talk to someone who's got behind one of these technologies and have a look at some before and afters and see if it sounds reasonable, because that would be the way to go. But if you came and saw me, if you've had liposuction and you've got redundant skin after liposuction, apart from an excisional procedure, I haven't got anything. I hate to say it. All I do is excisional procedures, tummy tucks and what have you, because I've not been able to get behind any of these ones. So that's kind of where I am. But it's difficult is the answer. It's difficult. Don't know if that's helpful, but it is difficult to address loose skin after liposuction. Fact. So thanks for that question. Really good question. I hope it's been of some help, that response. What have we got? Do you always need an internal mesh bra to stop future snagging or sagging when having breast augmentation? What? I'm not sure about this question. So an internal mesh means a mesh that you put inside the body. So there are such things as internal meshes, and they do report to reduce the risk of sagging in the future, but that's kind of more with breast lift. You can use these sort of internal scaffolds in breast augmentation if you're worried about the breast bottoming out or the inframammary fold descending. I don't ever use them pretty much. So do I always need them? So I never use them. They're really for, well, usually I would say for revision procedures where there's a problem that you might want to use them. The issue with them is that they are prosthetic materials, so there is always a risk of infection. It's all very well, we're worried about infection with breast implants, but if you get infection with the breast implants, you can remove it. Right? Well, if you get infection with a prosthetic mesh, often the skin or the tissues are kind of sort of grown into the mesh, which is kind of what's supposed to happen, but it can be difficult to remove them. So infection with these meshes can be a nightmare. And there's a lot of difficulties I've found with these meshes. You have to kind of anchor it to something, usually bone, bit of rib or something, to some immovable part of your body, that so the whole thing doesn't sort of sag, and then you can get pain where you anchored it. And so they're very expensive as well. So I don't use them. So I don't know why it says, do I always need an internal mesh bra? Yeah, I never use an internal mesh. I use an external bra, but never an internal mesh bra for breast augmentation. And yeah, it will be reserved for revision cases, which will be by definition be difficult and expensive. So no, personally, I don't use the internal bra simply because it's all very well saying, oh, I don't want them to sag, so this sounds really good having this internal bra. No one wants them to sag, but doing things like that brings with it extra potential for complications. So you've got to weigh up those complications versus the potential benefits, so you can make a decision on whether it's a good idea or not. So anytime that you find someone's doing something but not everyone's doing it, you got to think, why is not everyone doing it? Why is there only this 1, 2, 3 people doing it? I'm not saying it's bad, but I'm just saying there must be some bad things about it. Otherwise, we'd all be doing it. We'd all jump on and say, "Oh my God, these brilliant things stop sagging! Fantastic! Let's have some of those." But yeah, they are not without potential for problems. So I tend not to use the internal mesh bra personally. Personal view. Should you make any special precautions a month before a mastopexy, like traveling? No, that's absolutely fine. You can do anything you want. You can do traveling. If you smoke, you should stop if you can. And if you can't, probably shouldn't have a mastopexy, to be honest with you. So smoking's a nightmare with mastopexy. So smoking's important. Apart from that, no. I mean, there was a study a while ago which said, mainly for breast augmentation, we worry more about infection with breast augmentation. You've got to be careful with spray tan, like a week or so before the hi, is that Tanya? Hi, Tanya. Before the surgery, because of pseudomonas or stuff in the spray. So I guess maybe spray tan could be an issue immediately before a surgery, but I don't normally make a deal of that. Healthy, positive mindset, no special precautions. Traveling, well, obviously don't want to travel and get ill, but you know, don't want to travel get ill ever, do you? So it's a bit of a, not sure that's helpful. Do we offer papilloma removal? Hell yeah. Hell yeah. Well, it depends on where your papilloma is. Kind of, if it's inside your bowel, we wouldn't remove it. But if it's cutaneous, if it's on your skin somewhere, yeah, damn right we do. Show me a papilloma, I'll remove it. Yeah, send us a photo. WhatsApp me 07794739606. Remembers the number. Yeah, that's the number to WhatsApp your picture of your papilloma, and we'll tell you straight whether we'll remove it or not. We're not messing about here. We will give you a straight answer. Not only that, tell you how much it costs. Yeah, because that's what you all want to know, isn't it? Like Antiques Roadshow, that's all anyone wants to know. What's the cost? Do we offer macrotia surgery? So macrotia, as opposed to microtia, is a large ear. Now, this, I think we'd have to delve down into this a bit. I think questions need to be asked over this. What do you mean by macrotia? Because often the problem with ears, the most common problem with ears, is that they're prominent. So the ear is prominent, and people get called big ears, and people think they've got big ears, but they haven't. They've usually got prominent ears. So, you know, if you've got prominent ears, Yes, we have. We just restructure that cartilage and make that ear less prominent and bring it back towards your head. So if you have if you're saying you got big ears or a big ear, one ear is bigger than the other, can you make that ear smaller? So if that's what you mean, which is a rare situation, I'll be honest, my vast majority is like a prominence, which we get rid of the prominence. But let's just say that's what you're on about. That's a little bit difficult to do a macrotia, to make an ear smaller. You can do things like a wedge excision, so take a slice of cake out and it brings it down. You can do things like a conchal reduction, so the conch is this bit in here, so you can take some cartilage out and bring it down. So that's difficult surgery. I've got to be honest, full disclosure, I don't even do the prominent ear corrections anymore. Yeah, I don't do the prominent ears, so we've got other people at the clinic who do the prominent ears, so we would defer to them to see about Macrotia if we could help with it. But Macrotia kind of suggests perhaps a congenital abnormality, a bit like a microtia. A small ear is a congenital abnormality, and that would often be treated by an ear plastic surgery specialist, of which there are not many in the country. So it might require an ear specialist. It might not. If it's something like a conchal reduction, that's something we can do. Wedge excisions we can do because of, well, maybe not obviously, but we do them for skin cancers on the ear. Doing a wedge excision is a standard procedure, but it's quite a big deal to do that for a kind of congenital deformity for enlarged ear. So we'd have to have a look at it. We'd have to take a view on the Macrotia question. It suggests perhaps ear specialist, but as I say, send us a photo. It doesn't cost you anything. We'll give you an opinion and say, look, you need an ear specialist, or lean on there, or we can help you with that. So yeah. Why should you check the GMC register when kids considering a cosmetic procedure? Okay, well, this is something this maybe not this week, but I'll say in the last 7 days or so, we had a few people get in touch and say, I've contacted this other, clinic or whatever, and they'll do it for a fraction of the price. You'll do it. And Amy, who deals with all the inquiries, come and say to me, look, this clinic's doing it a fraction of the price, which we'll do it, and they want us to, get, I don't know, meet in the middle, or all these sorts of things. I will say we can't really do that. We can't really go discounting and things like that, because we're members of BARPS, which is Plastic Surgery Association, which has got a code of conduct. So kind of makes it a little bit easier. It sounds a bit harsh, but it makes it a bit easier for sort of Amy and things, that she doesn't have to negotiate prices. If you come and have something done and we charge you a price, we'll charge the next guy the same price. There won't be a situation where we would have, someone would have kind of haggled with us and got it for less. But the question is why, and Amy thought, why is it 3 times the price, or why is it more expensive here? And then you look at the clinic they're going to, and like one of them, they charge extra for consultations, they charge extra for histology. Those things are standard with us. We have this thing now, which I'm just introducing, which is, I say I'm just introducing, we've always done it, but I'm just making it a bit more of it's kind of verbalizing this, what we call the cast iron guarantee, which means it's the first 6 months after the surgery, we'll do any revisions that need doing, often with, not often, but sometimes with moles, prominent moles. If you do a shave excision, you don't get it all out, so you have to do another shave. That's certainly happened to me a few times. You have to do another shave. You might get too much out and give a dent. You might have to excise it. You might have to do surgery to make things look right. If you cut something out, there's a little bump at the scar, it doesn't look quite right. The bottom line is we won't charge you for revision surgery. Maybe no one does charge for revision surgery, I don't know, but that's probably something you should check with these other places. But the main thing that I found when I've looked at the other places is the training of the surgeons. So as I say, in the last few days we've had a couple. One was a GP. I'm not saying there's anything wrong with GPs doing procedures, because they do procedures, but it's about being aware that that person is a GP, where when you look at the clinic and what have you, you might be thinking they're a surgeon. So a GP doesn't have any surgical qualifications. They will be doing rotations, so they might have spent a few months in a surgical setting, but they haven't really got any surgical qualifications. And you know, I'm not saying they can't remove things, they can remove things, but that might be a reason why there's a price difference. The other one we looked at, which was today, was not even fully trained in anything. So it wasn't a trained GP, wasn't a trained surgeon, wasn't a trained specialist in anything. Now, they were on the GMC register, so you can check on the GMC register to see someone's on it. So they were on it, but they weren't on the specialist register. So basically, when you do medicine, you become a doctor, which is after 5 or 6 years at medical school, you become a doctor, and then you get registered with the GMC, and then you go through training in the NHS, leading either to being a GP or being a hospital doctor. And if you're a hospital doctor, broadly speaking, you're kind of like medicine or surgery or obs and gynae. So you're on the, and that means you get on the specialist register with the GMC. So if you're just on the register with the GMC, but you're not on the specialist register or the GP register, you haven't finished your training. You're either still training, or what happens, I think, with a lot of people is they give up and they say, look, I'm not doing this training thing. I'm just going to go in the private sector and open a clinic and do stuff. So, and that's what the situation was with the second one. I'm like, well, they're not trained in anything. They haven't got any formal surgical qualifications. They haven't actually got any formal, they're not a specialist in medicine or in GP or in surgery. They've maybe done a couple of months after, or I don't know what they've done. It's hard to know what they've done, but they've probably done some work after qualifying as a doctor in the hospital in a training setting, but then they've left before finishing their training, because the training is very long, and so not everybody goes through with it. And again, I guess, is there anything wrong with having them remove your mole or whatever? Or maybe not, as long as you don't think you've got a surgeon removing your mole. The problem in my experience often with these situations, if when things don't go quite right, or if there's any issues or any problems, they can struggle a little bit. Whereas if you've had a surgical training, you know, when you're used to being in theatre, used to doing operations and handling tissues, there may be an edge there, and that might be a reason for the difference in prices. The level of training, the level of aftercare, and also we do pride ourselves on the level of service we give to people and stuff like that. And I say, look, that's included in the price, you know, obviously. But yeah, looking at the credentials of your doctor is very important. Whatever you're having done, is, you know, if you're having a mole or you're having a breast implant or you're having a tummy tuck, whatever, it is important to look at the GMC register to see if they're on the specialist register. So ideally, they'd be on the specialist register. And if you want a plastic surgeon, they should be on the specialist register for plastic surgery. Probably the majority of the people doing plastic surgery are not plastic surgeons. So they're not on the specialist register for plastic surgery. They might be on the specialist register, but it might be for general surgery, it might be for ENT surgery, it might be for some other type of surgery. So they're not plastic surgeons. Now, yeah, that might be okay. You know, ENT surgeons do rhinoplasties, general surgeons do breast work. But it's kind of like, you know, as long as you know, is what I say, you know, as long as you know they're not a plastic surgeon, you know, they're a general surgeon or they're an ENT surgeon or whatever, because there are situations where you get people doing things outside of their scope of practice. They are specialists in one sort of surgery, and in the private sector, they're doing other types of surgery that perhaps they're not trained to do. And there's not an awful lot of there's no regulation of it. To be honest with you, there is zero regulation of it. So I suppose that's probably not fair. The private hospitals do try and regulate it. So if you have it done at Aspire or a Circle or Nuffield or one of the big hospital groups, they do try and put some degree of regulation on it that you're supposed to be working with within your scope of practice. But if you don't go to one of the big hospital groups and you go to one of the chains or one of the sort of, especially, you know, these cosmetic clinics, I think you'll find that there's all sorts of people doing all sorts of stuff. I saw something here. Hello, sir. I've followed you for a while. I can't read it. I'm going in for a fleur-de-lis, Daniel. Going in for a fleur-de-lis. Good luck, Daniel. Let's all give Daniel a big hand. Daniel, you're going in. Let's have a bit of positivity. You're going to smash it. Good luck with that. Hope it all goes to plan. Very excited for you. So yeah, thanks for following me for a while. It's nice to hear. Why wouldn't you recommend having multiple moles removed just for cosmetic reasons on the back? Okay, this is a patient that inquired recently, and they've got some moles on the back, they've got some moles on the front, they've had some moles on the back removed, the scar's quite stretched, they've got stitch marks, and I've got great cosmetic results. And one thing that I always say to people is that, yes, as plastic surgeons, we do everything we can to try and minimize scarring, tissue handling, looking at the orientation of the scar. But at the end of the day, the location of the scar is important. And scars on a lot of the stuff we do is on the face, and scars on the face heal well. The face heals well, and scars on the back do not heal well. Scars on the back will often stretch, they'll often be quite red, and it's so in that situation it's very hard to say to someone, oh, you've got all these moles on your back, let's remove them all because you don't like the look of them, because you will trade them all in for scars which might stretch, which might be a bit red, which might, to be honest with you, look kind of similar to the mole. And so is it worth it? Obviously, if you're worried about them, you think like skin cancer and you want to keep an eye on them, different story. Absolutely, let's get it off, get it removed, get it looked under a microscope for histology. So if you're worried about it, different kettle of fish, especially on the back, because it's hard to monitor moles on the back. But if you're doing it for cosmetic reasons, the back and the front, the chest, the shoulders, not a great place for a scar. And if you're doing it for cosmetic reasons, if you're doing it because you don't like the look of the mole, you might not like the look of the scar. So that's why it's I won't say alarm bells, but I'm like, oh, when someone sends a photo of lots of moles on their back and the front, I'm like, I'm going to give you scars, which, you don't like your moles, you might not like your scars. So you've got to think carefully as to whether you feel that is worth doing. Now, obviously, that's the last question. Obviously, I'm a busy man, and I'm very, very acutely aware that dinner is probably burning. But if you have any questions, I am open, and I'm very happy that, oh God, we've got one here. Is there a risk of blood transfusion with rhinoplasty? Number one, I don't do rhinoplasty. So, talk to your surgeon. If you're having a rhinoplasty, talk to your surgeon. But in my experience, personally, if I did do rhinoplasty, and I have done rhinoplasty, I would not group and save, which is like what you do to save some blood if you're worried there might be a risk of blood transfusion for a rhinoplasty. So I think the risk would be extremely low. However, sometimes the hospitals have a sort of view on things, even though it's a very low risk, they might still do a group and save on you. And even if it's a low risk, it might still be on your consent form if it's a very comprehensive consent form, because I have no doubt that someone somewhere has had a rhinoplasty and has had to have a blood transfusion. It's possible in the world, and but it's extremely rare. Is it possible to save your own blood prior to surgery? Well, you would have to wait a period of time for that blood to kind of replenish in your body. So otherwise you're sort of like going into surgery anemic, which isn't great. And maybe is the answer. I've never worked anywhere where that's been a thing. In the situations where people don't want to have a blood transfusion, some places will use something called cell salvage, where the blood is kind of sucked up when you're doing the surgery, and then they process it, and then they give you back your own blood. But that's really for bigger operations where there is quite a lot of blood loss to be sucked up. Rhinoplasty is just not worth doing because there's hardly any blood loss. That's what it means. The transfusion is extremely rare. I'm sensing, might be wrong, but I'm sensing maybe there's a reason you don't want a blood transfusion. And the problem in those situations is often, even though, I don't know what your situation is, I don't know what's going on with your surgeon and stuff, but I've had patients who don't want a blood transfusion, and I haven't been able to operate on them, even though I don't want I'm not planning to give them a blood transfusion, simply because the hospital you have to say you are willing to have a blood transfusion in order for the hospital to say, yes, we'll do that operation here. Because they're very sort of risk averse, and they're like, well, what if? I'm like, well, chance of them using a blood transfusion is very, very small. And they're like, well, that's not zero. So often it's the hospitals, is my point, that if, I mean, I don't know if they have got a problem with obstruction of, not being able to get your operation. I think, great, you're not keen on having a blood transfusion. Yeah, I don't think anyone's keen on having a blood transfusion, to be honest with you. Hands up if anyone's keen for a blood transfusion. No, I don't think anyone's keen for it. And usually in situations in cosmetic surgery, and as I say, rhinoplasty is not one of those ones, which is breast reductions, tummy tucks. Those are the ones where you would have more of a risk, but even then it's extremely rare to have a blood transfusion. And usually it's like you've lost a bit of blood, you feel really tired, jaded, lethargic, your blood count's low, and we'll say to you, look, your blood count's low, you will benefit from a blood transfusion, you'll feel straight away better. If you don't have a blood transfusion, it's going to take you several months to get on your feet and get feeling better. And if you say, I don't care, I don't want one, I'm going to take several months to get better, well then fine, just take several months to get better, don't have one. So, personally, I wouldn't push it. I'm like, yeah, okay, you don't have a blood transfusion, I get it. It's not high on most people's lists for a thing to have done. Is that the case? Even if you consented to not having it, hospitals still refuse to do the surgery? Yeah, well, depends on the hospital, but yes, in my neck of the woods, yes. Even if if you say that you won't have a blood transfusion, they won't do the surgery, simply because they don't want to be in a life-threatening situation where it's like, what do we do? They don't want a blood transfusion. Do we let them die? Because that would look bad, because maybe is everyone going to be okay with that, or do we give a blood transfusion and then work out afterwards, but then they'll kind of sue us because they said they didn't want a blood transfusion? It's a potentially difficult area if you say you don't have a blood transfusion and you're going in for an operation which has got a chance of having a blood transfusion. I'm not sure rhinoplasty is that sort of op, but the problems I've had is things like tummy tucks and breast reductions, which again, I probably have transfused, but I've never transfused anyone on table, put it like that. I probably have after the surgery, but even then it's very rarely done. But it's done under a situation where we can have a talk to the patient about it. But still, the hospital will say, look, if they're saying they won't have a blood transfusion, we're not doing the surgery. Yes, that is the case with the hospitals where I work. And we've had problems with that, with not being able to do the surgery. At the end of the day, it's their hospital. What can we do? We can't make them take the case. It's getting worse. It's worse since COVID. Everyone's become very risk aware and don't want to have to transfer anyone to the NHS and all this sort of stuff. So any sort of outlier in terms of medical history and things is kind of like I often find the hospitals like the answer's no. Now what's the question type thing. Right. Well, that was good. Thank you for that. User 93712273548871. So any last requests before I go and get my cremated dinner out of the oven? If you do have any requests next week, I'm pretty sure I'm here. If you're around, next Tuesday, same time, same place. So yeah, who knows? Might see you there.